Good evening. I'm Dr. Allan Perel, and this is Conversations in Medicine. This program brings cutting-edge medical topics to the Staten Island and tri-state community. Tonight, we're going to be talking about hearing, and literally hearing. It's an interesting sense. We have multiple senses, as we all know. If someone is blind, sad to say, we're all very empathetic. If someone can't taste things or can't touch or paralyzed, we're very empathetic. If someone's hearing is impaired, so many times we just laugh, and it's just a strange phenomenon. So I have an expert here in hearing. So we have a doctor of audiology, which is hearing, and I have Dr. Evan Bernstein here, so I want to thank you. And he's someone I know very well, who's taking care of my family. I want to say thank you. And really to enlighten us on hearing, because hearing is a very complicated topic. As a neurologist, we know hearing has a lot to do with circuitry, and it just even in anatomy. The hearing center of your brain is right next to the understanding part of your brain. So in order to understand things, in order to really be able to comprehend, you have to hear. And it sort of tells us why listening is so important. So thank you so much for joining me.
Thank you very much for having me. It's a privilege to speak with you about this very important topic, and does affect a lot of people out there. And it's an important thing that we should educate and talk to people about.
Let's talk about training. So what's a doctor of audiology, and how do you become one?
Sure. So when I went to school, it was a 4-year undergrad degree, and then you needed a 2-year master's. I graduated one of the last classes that only required a master's degree, but now I was grandfathered, but now you need a audiology doctorate degree, which is about a 3-year program after a 4-year undergrad. So it's 3 years of schooling, and then it's 1 year of going for like an internship or an externship. It's called a 4th-year externship. And that's a paid externship, and you could work in a hospital or private practice or the VA. But when I went to school, it wasn't required. It was 2 years of a master's and then 1 year of what was called the CFY. It was like a 3rd-year paid internship to get us our license. I went back later on to get my doctorate. They had programs. There were like 4 programs out there. One was in Florida. One was in Arizona, which is the one I went to. There was one in Pennsylvania, where it was meant for people like myself that were grandfathered into the system, and to go like at night, take about a 1.5 to 2 years worth of classes, and then we got our doctorate. And that's what I did. It was an interesting decision whether I should or shouldn't go back for it, because I had the experience. It wasn't like it was going to make me make more money or anything, but I felt it was important to really learn more about the field. I learned a lot about pharmacology, which was interesting, and there were other topics that we learned about that really does help me in this day.
So we see by your energy, obviously, that you're interested in this. But why hearing? Why audiology?
That's a great question. So I will attribute it to my mother. It was a speech pathologist. I always wanted to do something to help people, and I didn't know what to do. I'm, a good Jewish boy. We go to become a lawyer, we become a doctor, and I wasn't sure what to do. I always wanted to help people, but I was unsure of what I wanted exactly to do. My mother was a speech pathologist, and she said, "Evan, do audiology." I'm like, "Well, why not speech pathology? That's what you do." She's like, "No, go for audiology." So I started taking courses when I got to college. I was an undergrad, and I loved speech. I hated audiology. I really hated it. And when I before I applied for grad school, I was conflicted. What do I do? Should I maybe dual major? Should I only go for... So I decided to take audiology, and I'm so happy I did that, because when I got to grad school, I found that audiology, if there was a problem, there's a solution. That's my personality. If I see there's a problem, there's an easy solution. And you see that a lot of times with hearing loss. If there's a problem with your hearing, there's a solution to get hearing aids or surgery or different medical intervention. With speech, I found that it was interesting, but it was a very long process that you could, let's say you work in the school system and you're working with a child that has articulation errors, that process to help them could take a very, very long time. So maybe my ADD kicked in, I don't know, but I found in grad school I loved audiology. I didn't like so much speech pathology, so my mother was right.
So tell me, it's a science of audiology, hearing, but the ear does a lot more than just hear things.
Oh yeah.
There's the balance center there's other things. Is that part of what you do?
Sure. So audiology is, like you said before, the study of hearing and the science of hearing, but our scope really goes more than just hearing. One of the things in our scope is tinnitus and tinnitus, ringing in the ears. That's one of the big things that we deal with. Helping people with their loud noise that's in their ear. That noise is a subjective noise that they hear. It could be a high-pitched ringing, it could be a hissing sound, it could be a buzzing sound, it could be constant. So under our scope of practice, that's something we also help.
And I'm even going to stop you here because
Sure.
when in medical school days, if you actually look at a textbook for ringing in your ears or tinnitus or tinnitus,
Yeah.
the treatment for it was background music. So you actually see all this in the major scientific
Yeah.
literature. That was it. No medicine, no exercises, background music to drown it out. What kind of people, and I have patients who come in all the time
Yep.
with tinnitus in one ear or the other ear, maybe sometimes in both
Sure.
ears, and it's a very difficult and sometimes disabling issue. People can't
yeah.
sleep at night.
Oh, yeah.
What do you do for them?
It's an excellent question, and it really depends on what's causing the tinnitus or tinnitus. If it's something that could be corrected through medicine or surgery, for example, if you have wax in your ear, that's something that commonly could cause ringing in your ear. So if you get rid of the wax, that can help. If you have an ear infection, you have fluid behind your eardrum or a hole in your eardrum, again, medical intervention could help alleviate the issue. Or if you have, God forbid, a tumor, or if you have the bones behind the eardrum are not working well. These are all things that not only cause hearing loss, but also can cause ringing in the ears, tinnitus or tinnitus. If everything comes back clear, then we have a hard battle. It's not an easy thing. And exactly like you're saying, what most ENTs, when patients go to like ear, nose, and throat physicians or even neurologists, and everything comes back normal, the doctor's job is pretty much over. Your neurologist's job, the ENT's job, they're trying to rule out if there's anything medically causing the issue. Once their job is over, then the patient's still stuck with, hey, I'm still suffering from this ringing, the buzzing, how do I get rid of it? And that's when they come to us as audiologists. Do we have a 100% success rate? No. And if anyone ever tells you they do, they're lying to you. There's no such thing as 100%. But there's different things we do. One thing, like you mentioned, background noise. Well, we do something called like sound therapy. It used to be back in the day, people used these things called maskers. I was never a big fan of maskers because maskers are just like type of noise that you're using to cover over. But there's other things that we use. We use sound therapy in a sense to sort of desensitize the brain and the nerve from hearing the tinnitus and tinnitus. Can we get rid of it? Probably not, but we do like to at least try to lower it as much as possible where it's not affecting people. But including that, we also educate patients. We educate them to not be around silence, try to have something always on in the background so your brain isn't focusing on that, as well as staying away from salt, staying away from caffeine, fatty foods. These are things that can trigger the tinnitus or tinnitus to get louder and lower. So we try to educate as well as provide these other type of therapies as well.
If you watch television, which many of us do, you see cures or panaceas for even something
Yes.
like tinnitus.
Yeah.
What do you think of those?
Lipoflavin. You see that one, the big one. I'll tell you a funny story. When I was taking my my doctorate, when I was going back, one of the classes I took was on tinnitus and tinnitus. And the question, the paper for the whole semester was, what do you think about these over-the-counter things? Do they work or not work? So back then, I don't know if anyone remembers, the audience remembers, on the radio they always had this ad. It was called Quietus. Okay, it was so
Good name.
Yeah, Quietus. That's what they called it. And the guy was talking how amazing it is, and it's going to cure you. And I had tinnitus, so I was going to look into it. And I remember speaking to my professor and saying, what's the big deal? Let someone take it. If it helps, great. If it doesn't, doesn't. And I'll never forget, she started yelling at me. And she's like, did you even look what's in there and who developed it? So I started, digging a little deeper. And it was made by a drummer of a band who had tinnitus. And he put all these different concoctions into this pill. And he said it worked for him. But if you did any research, it was all these supplements and not even things that have any backing or any research. So I'm very skeptical. There is, when it does come to tinnitus or tinnitus, there are some psychological aspects to it where a person will, if they pay attention more to it, if they bring more attention to it, it does get louder, exacerbates. But the way you try to get away from it is sort of not thinking about it. So if you feel that this is going to help you, maybe there is something to it, but to say that that's going to cure it is no cure.
Tough problem.
Yes.
It really is. Now let's go on to hearing.
Okay.
Hearing sort of the crux of what you do, and as I said, my family has seen you. Tell me a little bit about hearing and audiology, and how do you help people, and how do people know whether to come to you or not?
That's a good question. And, the most common situations really occurs, it's not necessarily the patient coming in that is the one that's noticing the issue. It's more the family members are the one bringing in the patient. I used to work with a very well-known ENT doctor. He actually comes to Staten Island once a month. He's a very twice a month actually. He's a huge surgeon, Dr. Neil Sperling. He's in the city. He's top of the line type of ENT. And he used to always tell patients that the patient is always the last one to know they have the hearing loss, because everyone around them knows that they're repeating themselves. The TV is very loud. They're just sitting there like with that blank stare. What's going on? So a lot of times it's not necessarily the patient that's noticing. It's more about the family members are the ones bringing them in to seeing us.
So people don't always recognize it themselves, you said. So what are the implications? So first we say, a number of my patients come in and I talk to them about their hearing problem. How do I know? Because we're in a dark room, we're in actually a small, well-lit room, but very close to each other, and it's very quiet. And if I say something and they keep saying what, or they don't understand it, if I ask them to repeat some words and they repeat different words, I always use the same words, bus, door, and rose. Yep. And if bus becomes bud and rose becomes road, that's my own little clue that they have a hearing problem. First response is, it's just the way it is. It's age-related, and it's no big deal. Is it a big deal?
Yes, and I think that's part of the education. And another thing that we were speaking before about, that one of the big things even with the patient, if they have hearing loss, so they'll make the TV a little bit louder. Or if they're living by themselves, no one's there to say, hey, the TV is blasting. Or if you call them on the phone, you could hear the TV in the background. But there are significant things that do happen when you do have hearing loss. It's not just, oh, I can't hear, I'll deal with it, or it's their problem, it's not my problem. So when we deal with hearing loss, we deal with a lot of different aspects. First, there's a social aspect, that if a person has hearing loss and they're not doing anything about it, they tend to start to socially isolate themselves. So if they were going out with friends before, going out to dinner, even with spouses and friends and family, and everyone's laughing and everyone's having a great time, and they're sitting there like not knowing what's going on, they don't feel too smart over there in that situation. And they start to say, you know what, everyone was having a good time and I didn't enjoy myself, so I want to take a step back. And they start isolating themselves, which is a terrible, terrible thing. We don't want anyone to isolate themselves, especially if it's something that could be preventable. So that's in terms of the social aspect. But there's also the cognitive aspect, and this really ties in really to your field a lot, that there were so many studies done even in Johns Hopkins University by Dr. Lin, where he spoke and he showed that, like you were saying, that there's this link between our hearing and our understanding. So there's two things. There's hearing, how we hear the sound. That's like when you get a hearing test and the doctor tells you, hey, raise your hand when you hear the beep, 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 just like you did when you were in school. Mm-hmm. That's your hearing. Those are the levels of your hearing. That's the volume of your hearing. But one of the tests that we also test is to see how the brain understands and processes the sound once the brain could hear. And to me, that's probably the most important test I do, because it gives us sort of like that pathway and that gateway into how a person is doing cognitively and how they're understanding the sound. So when you're not hearing the sound accurately, the brain, like any muscle, starts to forget it and gets weaker. And the brain gets weaker and weaker, starts to forget the sound. So when you decide to do something about it, and you decide to address the hearing loss, well, it might be a little bit too late, because now when the sound gets to the brain, if the brain doesn't understand it, it doesn't make a difference what you do at that point.
Because I've seen patients and people substitute words that they think you want to hear, or whatever they think you want to hear.
Right.
So, as I said, rose and road,
Yeah.
and the words become jumbled and changed. What about with regard to truly with cognition, so
Yeah.
with memory issues?
Yeah.
Patients, people who have memory issues, and I'll say this from my own experience, they look much worse if they don't hear well.
Yeah.
And what do you see with that? And do you think people get better with cognition when they hear better, when you do help them?
So that's an excellent point and an excellent question. And it's one of my goals, which I love. And I actually have a folder in my office of all the different patients that had a certain score on their which we call word recognition, which is essentially how the brain comprehends sound. And ideally, normal hearing people, we want them to have 100%. As we start getting more hearing loss and not addressing the hearing loss, those numbers go down, 90%, 80, 70, 60. And I like to see what patients are before they do something about their hearing loss, and then 6 months into it, a year into it, and to really measure that progress that happens. My goal personally is people should either stay where they are or get better. When they get worse, that's a bigger indication of something else going on. But the best way really to explain it is when someone comes and says, I hear what you're saying, but I don't understand what you're saying. That's the cognition. That's how the brain is understanding or recognizing the sound. Even like when you were saying that if you said one word they heard you, but they understood and processed it a different way than what was being
And there
said.
are treatments for that?
So that's where it gets more difficult. The treatment, there isn't much treatment with that. It's stimulating the brain with sound, and as much as we can do. It also depends on other type of issues if the patient's having any other medical issues, medications. These are things that also can affect it. But if we're dealing with, let's say, a normal 60-year-old gentleman or a woman that, worked around loud noises, has a mild to moderate hearing loss, and their word recognition scores are, let's say, 80%. If they're wearing hearing aids, I would hope within 6 months to a year, those scores are going to be the 90 to 100%. That's our goal.
So let's talk about risk factors. You talked about working around machinery, going to rock concerts. What are two parts of the question. What are the risk factors for having hearing loss? And the second is, does everyone get it? Does everyone, and that turns into one of these conversations, and when I, at the open, said, people giggle. Do I have hearing loss? Huh? And for some reason, hearing is somewhat of a malign sense.
Right.
People laugh about that. Nobody would laugh, well, I can't see out of my eye, or I can't move my arm, but they would laugh if you can't hear.
Right.
So tell us a little bit, risk factors for
But
hearing
even like
loss.
you were saying, that I think there's this perception that wearing a hearing aid is old, which is not really the right perception, because we're seeing now with different technologies out there that they're actually pretty incredible what they can do in terms of hearing people, but also working with your iPhone and balancing and things like that. But in terms of the rock concert, yeah, we get that. When I'm taking a case history of patients, they're saying, well, I went to so many discos in the 70s, or I went to Woodstock in the 60s, I have rock music, and they had the headphones on their ears. Even the younger generations, which is a bigger issue. There was actually a study done recently by one of the manufacturers, hearing aid manufacturers, and they saw that in high school students, about 10% of them had some degree of hearing loss because of all the gaming that they're doing, or listening to their AirPods or their headphones and the music. They're real dangerous levels. And in fact, Apple was sued many years ago because they didn't have a limitation on how loud the sound was getting. It was getting to very loud levels, so they had to readjust it and make it lower. So it does have an effect on us. Long-term use of noise does have an effect. Now, if it's a short-term thing, probably won't do too much damage. But even when you do get, let's say, a lot of noise exposure, there are different types of hearing losses. You could have a temporary shift. So if you went to like a concert and you were right by the speakers, you could have that shift in your hearing for maybe 24 hours to 48-hour type of shift. And you could also have the noise, the ringing in your ears. Usually that does come back. But the long-term effect is that you've already caused some type of damage. Now, if you keep your ears healthy the rest of your life, there probably won't manifest much more into that. But if you continue to not keep your ears healthy, it does continue to damage those outer hair cells.
So we're going to go quick now. Prevention, anything that we could do to prevent hearing loss?
Wear earplugs. And stay away from loud noise.
Okay. Anything else? Taking wax out of your ear, putting the stuff in
So
your ear.
the funny thing is, wax is actually protects your ears from types of infection and dirt and noise, believe it or not. It works as a layer. Now, it's not a good thing to have because it does affect your hearing, but it's more about staying away from those loud noises. But if you have to be in those loud noises, really wear the earplugs. Try, even if you're working gardening outside and you're mowing the lawn, you should really try to wear earplugs.
So now we're going to jump into what everyone wants to hear about, hearing aids. So if you have a hearing deficit, does everybody who has any hearing problem need a hearing aid? Is there anything they could do before that? The hearing, and maybe we'll just start with that, because I want to try to get an idea of what a hearing aid is. And you've taught me it's not just a microphone.
No, it's definitely not.
And that's a big deal, because everybody thinks about it. We'll talk about the Costco's of the world and people on TV who look at these little devices that just amplify sound.
Sure.
So tell us a little
So the way I like to really make it very easily understand is that there's three type of categories. There's your first category, which is like an amplifier. When you're on the TV and you see these $49.99 things, Nano is a big one, MD Hearing. They advertise as hearing aids, but they're not hearing aids. They're amplifiers. So what an amplifier is makes things louder. So it makes the voices louder, and at the same time, it'll make the background noise just as loud. So it doesn't really do too much, except when you're in like a very quiet situation. Then it can help you a little bit. There are some amplifiers that are very good that I do recommend when patients are in hospitals. They're called like pocket talkers, where someone would wear like a headphone and there's like a little microphone, you could talk into it. These are certain amplifiers that can help in specific situations, but most of them are not that effective when it comes to hearing. And the problem with an amplifier is because your hearing levels are probably different at all the different levels, you might be actually damaging your hearing. So that's the first category I like to explain. Then there's a second category, which was essentially created maybe about 2 or 3 years ago, which is called the over-the-counter hearing aids. And what these were meant for were people who want to self-fit themselves with hearing aids. And they're called over-the-counter. Jabra is a big company out there that does it. And there's a few companies out there. Bose got into this space at one point. And basically what you're doing is you're taking an app or you're taking your phone and you're programming the hearing aid to your hearing loss. You might take a hearing test on your phone, or you might get a real hearing test from like a doctor of audiology like myself, and then you're sort of fitting and self-prescribing the hearing loss for yourself. The only problem is it's only meant for like a mild to moderate hearing loss. So if you have more than that, it's not an effective mechanism to really cure your hearing. And then the third category is what we do more, is those prescription hearing aids. And prescription hearing aids are really the best way to give the right amount of amplification for your hearing loss at all the different frequencies. Because when we test the hearing, we're not just testing sounds, we're testing a whole array of different frequencies, which are very important for speech. And when we're programming the hearing aids, we're programming at each specific frequency to make your hearing more balanced and more clear. And on top of that, the hearing aid itself has what we call noise reduction, to lower the background noise while keeping the voices nice and clear. Amplifiers and the over-the-counters don't have as good of technology when it comes to the suppressing of noise, background noise.
So give me an idea about percentage of patients. When someone comes in with a hearing loss to you and they say they need a prescription hearing aid, are you able to get most of those people to hear okay? And I'm saying it's obviously not perfect, but
no,
okay.
So it's an excellent question, because we have to go back to, it's not just the hearing levels. There's a few factors. There's the hearing levels, which is important. There's also that cognitive aspect. When you're hearing the sound, how well does the brain process it? And you always hear from patients, oh, my cousin had a hearing aid, my aunt, my friend, and it didn't work for them. They couldn't do any, they didn't hear. But so much goes into it. It's how does the brain understand? Because I always go back to that. How does the brain understand the sound once the brain hears it?
Because the ear is connected to the brain.
Exactly. So if your understanding is very poor, well, yeah, then a hearing aid will help you, but you have to really be realistic about how much it's going to be able to help you. But more importantly, and this is something that's really neglected by a lot of people, even within my own field, doctors of audiology, hearing aid dispensers, Costco is specifically also, there's a test that we do, it's called real ear measurement. And the only way we're able to verify whether a hearing aid is programmed accurately is running this real ear measurement. It's such an important test to do, because just putting your hearing loss into a computer, even self-fitting yourself, putting hearing aids on your ear doesn't accurately tell you how the hearing aid is working in your ear. So you might think, oh, I'm giving myself the proper amount of amplification through a prescription, but without running that real ear measurement, which is these electrodes, these tubes we put into the ear, and we measure soft sound, medium sound, loud sound, and speech, we are able to see in the ear how the hearing aid is functioning, and we're able to make adjustments in real time to really perfect that sound for you. And if you don't do that, you're spending all this money and you're not getting what you need, and you're not getting accurately programmed.
So you mentioned money.
Yeah.
So people talk about it. Sometimes they laugh at the cost, and we see the commercials, they talk about it. Why are they so expensive?
It's a great question. And there's been a lot of lobbying, especially from our field, about, there should be some type of option for people on Medicare, because Medicare does not cover them. And it's really a travesty that they don't cover it. There should be some type of coverage for Medicare people, because these are really the clientele that need it. They should have something that is, even if it's a basic type of hearing aid, but it should be something that should be available for Medicare patients. But the cost is expensive. They are expensive. And you have all these different companies out there, all these different manufacturers. And the reason why I think it's expensive is the actual thing to make is probably not expensive, probably costs pennies. But there's so much research and development that goes into it to know that, hey, this type of sound and this hearing aid or this noise reduction or this situation you're in requires X, Y, and Z. And there's hundreds of millions of dollars that goes into it. It's like any drug. How much does it cost to make a drug? Not much. But all the research and development that goes into it, that's where the cost really goes up. On top of that, with the audiologist like myself, there's a lot of time that we do spend with patients. I mean, I personally love spending a lot of time. I don't like to rush my patients. So seeing them often, especially in the beginning, and seeing them over the course of 3, 4, 5, 6 years. And I always tell patients, if you keep your hearing aids in good condition, and even if your hearing goes down, it's not a big deal. We could always adjust them and recalibrate them for you. If you come in for your follow-ups, you come in for your 6-month follow-ups, and we test your hearing, we keep your ears clean, keep the hearing aid. You can keep it as long as you can. We can always adjust it, and we can always make them louder. We can always fine-tune it for yourself. So it's really, how I look at it, is more like a long-term investment. Yes, they are expensive up front, but if you have it over 5, 6, 7, 8 years type of thing, even longer, I think it's a good investment to help, with your brain, and really stimulate the brain.
Tell me about patients that hearing aids don't work for.
There's a lot of those.
What do you do?
So in New York State law is all hearing aids come with a trial period. And what I do during the trial period is I see, like I was telling you before, the patients pretty often, every week, to make fine-tuning and making adjustments. And at the end of that trial period, which is 45 days in New York State, a patient has a decision to make. They can either keep it or they can give it back. Now, the 45 days, if they need more time, I'm always...
I'm not even getting into the cost, the time.
Yeah.
What do you do if someone's hearing is so severe that it doesn't help?
If it's so severe and the hearing aid is not good, then we go into what's called the cochlear implant, which are amazing, fantastic, but it's a surgery. And it's a pretty serious surgery. They do implant something into the skull, into the brain, not the brain, but into the skull. And there's healing process, there's anesthesia for the surgery, and you're not turned on. The skin and everything has to heal. It takes a good 6 weeks before you're actually turned on, before you can start hearing. So there is a process, but if you are a candidate and you go for it, it's a fantastic option, and it doesn't have the limitations of what hearing aids do, because what they do is they put electrodes directly on the nerve into the cochlea, and they stimulate those hair
That's
cells.
a relatively recent phenomenon, not the cochlear implant,
Right.
but the idea of how widely it could be done.
Yeah.
Most ear, nose, and throat doctors are doing it now.
Yeah.
So tell me about it.
So what's good about it also is that it used to be you had to have a certain criteria to get a cochlear implant. You got to have like a profound hearing loss or severe hearing loss, like really, really at the end of the spectrum. But over the last few years, they've changed that. And they've made it a little bit easier for people to, because it is an expensive surgery, and the actual processor, the actual cochlear, is pretty expensive. So insurance companies do cover it. It's a covered service by insurance companies. So they've made it a little bit easier to get that if you want. Again, it's a surgery, there's a risk, but it's a fantastic option, especially now with the technology. They make them with Bluetooth, they connect with, that was never an option years ago. You couldn't, they never even thought about Bluetooth when it came to these cochlear implants. But
And
now,
we only have 30 seconds left. Tell me about where to put the hearing aid, in the ear, around the ear.
Both.
Does it make a difference?
It depends on the hearing loss, and it depends on your ear canal, your size. If you get a lot of wax, you don't want to plug up your ear. Also, if you have a very significant hearing loss, you want to plug up your ear. So it's a hard question to answer.
Okay. So with that, I want to say thank you. Thank you to Dr.
Thank you very
Bernstein.
much for having me. I appreciate
it was
it.
very enlightening. And I want everyone out there not to snicker when someone has hearing loss, or especially if it's you, and say that it was because I'm getting older, or it was a rock concert back in the 1970s. It's basically something that can be treated. And not being able to enjoy that sense of hearing, I think is really very sad. And what we learned from Dr. Bernstein today is that all of us can have better hearing with prevent loud noises, cleaning your ears out from wax. But really the idea is there are treatments available for everyone, from the people who have very severe hearing loss to the people who have milder hearing loss. And I want to thank you so much for being such a wonderful guest.
Thank you. I appreciate it.
Thank you. Have a good night.